The lecture of today is about the soft tissue management around implants. And I will cover first the treatment of the soft tissue defect we can find at the buccal aspect of osteo-integrated implants. So I'm not speaking at all about the problem of periimplantitis or how to face and how to treat the problem of periimplantitis. Periimplantitis is an infection with contamination of the implant surface and loss of bone, which is not exactly the topic I'm going to cover today. I'm going to speak about the treatment of all defect which belongs to the buccal aspect of the implant, which may be due to bad implant installation, bad implant angulation, too much apically position of the implant, which create the condition for the soft tissue to recede. And so it's mainly called soft tissue dehiscence around implants. And I will start with the treatment of soft tissue dehiscence because this, I think, will make you better understand how it is important to prevent this problem by making soft tissue augmentation during implant installation or sometimes before implant installation. So these lectures will be divided in 3 different parts. The first one was the treatment of soft tissue defect around the implants, and the second is the prevention of the soft tissue defect around the implant in 2 different situations. One is the case of tooth extraction for dental reason. So we have fracture, we have root resorption, but the patient does not have any periodontal disease. And the second big problem that I'm going to face is the case of tooth extraction for periodontal reason. So the tooth has been extracted because there is a lot of bone loss all around the tooth, so that this tooth cannot be saved with a periodontal regenerative procedure. And so how can we solve, from an aesthetic and from a functional point of view, the extraction, how can we substitute this tooth that has been extracted for periodontal reason? And this also to prevent to have any aesthetic problems after implant installation. So if we start at least theoretically on an ideal situation is always the situation in which the implant is the consequence of tooth extraction for dental reason. So it means that the patient does not have any periodontal disease, and there is also a very healthy situation at the level of the adjacent teeth. In this situation, we always have to look, in order to succeed in terms of aesthetics, to the adjacent, homologous, natural tooth. And of the adjacent, homologous, natural tooth, we don't have to look the cemento-enamel junction, which is something that most of the time we don't see because it's covered by the soft tissue margin that in the ideal situation also cover the cemento-enamel junction of the healthy tooth. So the reference point for every single decision we are going to make around our implants, and in particular where do we want to place our implant, depends on the position of the soft tissue margin of the adjacent, healthy, homologous tooth. Because obviously what we want to get at the level of the edentulous area is a tooth which is as much as possible similar to the adjacent natural tooth. So what we have to do is to reproduce this red line exactly at the same horizontal level, but also with the same shape at the level of the edentulous area. So we take this line and we split it horizontal in order to put the zenith in the right position, exactly in the same position of the natural tooth at the level of the implant-supported crown, and this red line at the same level with the opposite orientation is the soft tissue margin of the implant-supported crown. This is the ideal position of the soft tissue margin of the implant-supported crown. And now, the most important question we have to ask ourselves, and we have to ask also to the literature, is where are we going to place our implant platform, namely the head of the implant, that portion of the implant that can be osteo-integrated. How many millimeters should be this platform placed with respect to the soft tissue margin of the implant-supported crown? Because obviously there should be a distance from where the implant surface, we can say the rough implant surface, that portion of the implant surface that can be osteo-integrated with respect to the implant-supported crown in order to give the right emergence profile to the crown and give to the supra-bony component, namely that portion of the implant which goes from the platform to the soft tissue margin of the implant-supported crown, a nice shape which is good from an aesthetic point of view, but also it's easy to be maintained from an hygienic point of view by our patient. We also have to consider, when we decide how many millimeters is the right position of the implant head with respect to the soft tissue margin of the implant-supported crown, where is the bone? Because we want that the head of the implant and the platform is completely covered by bone. And if you also look the position of the bone of the adjacent natural tooth, you can see that the bone normally is a distance from the cement enamel junction and from the soft tissue margin of the adjacent tooth of about 3-4 millimeters, because this is physiological in an area where normally the bone is quite thin. Most of the patients undergone to orthodontic therapy in order to realign these teeth perfectly in their mouth. And so most of these patients have the bone which is not exactly at 1 millimeter distance from the cement enamel junction, but it's always 2 or sometimes 3 millimeters, which means 3 to 4 millimeters with respect to the soft tissue margin. So if you want to have bone, and now we have to see and we have to understand that the bone that is covering the tooth at the buccal aspect of the teeth is very, very thin. And when this bone that is covering the buccal surface of the root is so thin, this is mainly consists of bundle bone. Bundle bone means alveolar bone proper, which means that the origin of this bone depends on the periodontal ligament cells and not from the cells coming from the mesenchyma, which are cells that are capable to produce alveolar bone. And so it's not said that where we can see in the apical coronal dimension the bundle bone of the adjacent teeth, we may have also alveolar bone covering the surface of our implant. If we place the implant in the same buccal lingual position of the tooth, we for sure cannot have bone at the buccal aspect of the implant in the same apical coronal position of the tooth, because we don't have the periodontal ligament in the implant. And so for sure the implant must be placed more palatally in order to have a greater space from the, let's say, genetically determined position of the alveolar bone that we can call bone housing, and the position of the implant, so alveolar bone can be present with enough thickness at the buccal aspect of the implant in order to have bone at the buccal aspect also after implant installation. And we know that the thickness of the alveolar bone we should have at the buccal aspect of our implant platform should be about 1.5 millimeters thick. And so in order to have 1.5 millimeter thick of bone, almost at the same apical coronal dimension of the crestal bone of the adjacent tooth, for sure we have to place our implant in a more palatal position. But it's also true that if we go too much palatal, the risk is to create an emergency profile of the suprabony component and the implant-supported crown that it's so horizontal in order to displace the crown at the same level of the adjacent tooth that is not possible for the patient to clean it and therefore soft tissue to maintain the integrity of the soft tissue margin. Because this horizontal profile, as you will see in some clinical cases, when you place the implant too much palatally, is not easy. It's like a horizontal pocket that the patient is not able to clean. So we have to accept a compromise between the apicocorneal dimension and the buccal lingual dimension of this implant in order to give good aesthetics, easy maintenance of the patient, and right emergency profile to the implant-supported crown. And this is something that we can discuss a lot, but I have to tell you that there is a quite, let's say, agreement also in the literature that the distance between the soft tissue margin and the head of the implant should be at least 3.5 millimeters in order to give at the same time in good emergency profile in apicocorneal dimension and at the same time a palatal positioning of the implant that gets out almost at the level of the palatal cingulum of the tooth in order to leave enough bone at the buccal aspect of the implant and so not to have any bone dehiscence at the buccal aspect without the need to go too much palatally, which create the condition of not a good emergency profile in the buccal lingual dimension. So to this question mark, I can think that we can give this number that is from 3 to 3.5 millimeters, no less, because you know, if we speak about 3 millimeters, which is really high risky, we speak that the bone should start at a distance of the cemento enamel junction of the adjacent tooth at a distance of 2 millimeters, because 3 is the distance from the soft tissue margin, which is about 1 millimeter more corner. And you know that at 2 millimeters from the cemento enamel junction of the adjacent tooth, there is no bone at all, because there is the root that is exposed. And so in order to have bone, it means that you have to place your implant very, very palatally, and this could be too much. So sometimes it's better to accept the compromise. Instead of placing the implant only 3 millimeters to the cement, to the soft tissue margin, it's better to place 3.5. So this allows you to place your implant a bit less palatally and create a good compromise in apicocorneal and buccal lingual profile of the emergency of the suprabony component of the implant and of the implant-supported crown. So we can start with at least one fixed reference that we should have our mind, that every single time we place an implant in the ideal situation of the homologous contralateral tooth, we should place an implant at about 3.5 millimeter distance from the soft tissue margin of the adjacent tooth, which must coincide with the soft tissue margin of the implant-supported crown. And this will allow to have enough bone thickness at the buccal aspect of your implant without the need to place your implant too much palatally. This is the good compromise that all the literature is quite in agreement about this topic. So it means, this means that from the ideal or the true realized position of the soft tissue margin of the implant-supported crown up to where the buccal bone covers the implant, there is always a space of about 3.5 millimeters. And in this 3.5 millimeters of space, there is only soft tissue and not bone, because bone starts more apically, that is protecting the implant-supported crown from gingival recession to form. Because if we speak about gingival recession, so anesthetic appearance of the implant-supported crown, we don't have to expect only the metallic exposure of the implant surface. If we have metallic exposure of the implant surface, it means that the 3.5 millimeters, which belongs only to the soft tissue, has already been exposed, and due to the absence of buccal bone, there is also the exposure to the oral cavity of the rough surface of the implant that could be osseointegrated and was not. So it means that now the implant surface is contaminated. It means that in order to succeed in every single type of treatment we want to make, we have also the problem of decontamination of the implant surface. And when we get to the implant surface decontamination, this is the problem, that we don't know how to decontaminate the implant surface in a predictable way. And this is the problem of perimplantitis. So we don't have to treat this patient when it's too late, and our treatment becomes not so predictable because we don't have any mean for sure to decontaminate the implant surface, especially if this is a very rough, complicated implant surface with respect to a machined, smooth implant surface. But I don't want to speak about decontamination of the implant surface because we have to make our treatment before the surface is contaminated. And you know that gingival recession, which means anesthetic appearance of the implant-supported crown, starts once the soft tissue margin of the implant-supported crown is located 1 millimeter more apical with respect to the soft tissue margin of the adjacent tooth. So there is a disalignment of the soft tissue margin between the adjacent tooth and the implant-supported crown. The patient is unhappy even once gingival recession is only 1 millimeter, because one tooth, the implant supported, is longer than the adjacent tooth. Then you may have 2 millimeters of gingival recession. Again, if you have 2 millimeter recession, it means that the implant supported crown is 2 millimeters longer than the adjacent tooth. And so the patient tells you, I don't like these two teeth because they have different position of the soft tissue margin. And this is already an aesthetic problem for the patient because one tooth is longer than the others. So recession. At the 3rd millimeter of gingival recession, maybe it can appear the metallic or the surface of the abutment, which is the suprabony component of the implant, which can become exposed. And if this is metallic, the patient is even more unhappy because together with the elongation of the tooth, implant supported, there is also the metallic exposure. And only at the 4 millimeter, because we are 4 millimeter distance from the soft tissue margin, the patient can also experience exposure of the rough surface of the implant if there is no intact bone. But this is the 4th level of gingival recession. We have to treat the patient since the level is the first one, elongation of the implant-supported crown with no metallic exposure, at least abutment exposure, and we don't have to make too much late diagnosis, because if we are too late, also the implant surface can be contaminated, and now our treatment becomes less predictable. So it's very critical for me that you understand this very, very basic concept, that gingival recession starts from the soft tissue margin of the implant-supported crown. And the first gingival recession is that one that creates a disalignment of the soft tissue margin, and the implant-supported crown is longer with respect to the adjacent natural tooth. And this is true until we reach the area where there is the platform, the head of the implant, which is about 3.5 millimeters more apical. In this 3.5 millimeters, the only thing that can protect this implant-supported crown from gingival recession to form is not the bone, because the bone starts 3.5 millimeters more apical. The only thing that protects gingival recession to form here is the thickness of the soft tissue covering the implant-supported crown and covering the suprabony component of the implant, which cannot be covered by bone, because the bone starts 3.5 millimeters more apical. And so now, if we compare the two different situations, the tooth in which the gingiva is covering the root for 3.5 millimeters in the absence of bone, with respect to the comparable situation at the level of the implant-supported crown, in which the soft tissue is covering the implant-supported crown for 3.5 millimeters before the bone, is it the same thing? Is it the same thing? Implant and tooth is the same. Is the gingiva here attached to the root in the same way in which is the gingiva attached to the crown and to the suprabony component of the implant? Absolutely not. We know that at the level of the tooth, in the healthy situation, the connective tissue fibers of the gingiva insert into the root cementum and becomes part of the extrinsic fibers of the root cementum. So it is really a fibro-integrated structure in the mineralized tissue of the teeth, which is called root cementum. It's called connective tissue attachment. The connective tissue attachment is something that is so strong, that it's so stable, that we have always above the bone crest in the healthy situation some connective tissue fibers covering the bone and protecting the bone and inserting the root cementum. So is the same quality of the attachment, the gingiva for 3.5 millimeters with respect to the implant-supported crown or the suprabony component? Absolutely not. We call this area transmucosal soft tissue. It's a nice soft tissue that we like to have in order to make the crown emerge from the soft tissue exactly in the same way of the adjacent natural tooth. But this tissue is not attached at all to the underlying crown or to the underlying abutment or to the underlying suprabony component of the implant. It's a pocket. It's a tissue that is there for an aesthetic reason, which creates a nice emergency profile, but is not attached at all. So we have to think, can gingival recession form exactly in the same way at the level of the tooth or at the level of the implant-supported crown? Is the mechanism of gingival recession, the pathogenesis of gingival recession the same? Maybe we can see that plaque accumulating in the subgingival environment, tooth-brushing trauma can be the etiological factors which can create gingival recession in both situations. But in one case, tooth-brushing trauma and subgingival plaque accumulation might also destroy a connective tissue attachment. While in the other case, plaque and toothbrush should also create an inflammation, an inflammatory process inside the connective tissue that make this connective tissue shrink. And what does this depend on? It depends on how thick is the soft tissue. So if the connective tissue of the soft tissue protecting the implant-supported crown is thinner or equal to the area occupied by the inflammatory process, which is about 1, 2, 1.3, 1.5, there is a range from 1 to 2, and we don't know for sure how much it is. We can say that maybe in mean value, we can consider that the area of the inflammatory process created by subgingival plaque formation or tooth-brushing trauma is 1.5. So if the thickness of the connective tissue where subgingival plaque accumulation form or where toothbrushing occurs is less or equal to 1.5 millimeters, it means that the whole connective tissue is invaded by inflammatory cells, and there is no more healthy connective tissue that sustain the soft tissue margin, so the soft tissue margin recede. We know that in a thin biotype, gingival recession forms. While if the thickness of this connective tissue, where toothbrush trauma or subgingival plaque formation form, is thicker than 1.5, so 1.82 millimeters, there is an area of this connective tissue that is not invaded by the inflammatory cells, even in the presence of plaque, even in the presence of toothbrushing trauma, which continues to give support, blood supply to the epithelium, where the sulcular and extraoral epithelium meet, namely at the level of the soft tissue margin. And so those soft tissue margin does not recede. Maybe a pocket will form because of the proliferation of the epithelium, but not gingival recession. So in other terms, we have to ask ourselves, which is the minimum thickness of the soft tissue for a pocket, so that this remains a pocket in the presence of subgingival plaque or toothbrushing trauma, and this pocket does not become a gingival recession. And this minimum thickness must be greater than 1.5 in terms of connective tissue. And then, when we speak about soft tissue, we have also to include the epithelium, which is about 0.2, 0.3, so we can speak for sure that the minimum thickness of the soft tissue protecting the implant-supported crown for about 3.5 millimeters before reaching the bone, that can protect this soft tissue margin from gingival recession to form, even in the presence of subgingival plaque formation of toothbrushing trauma, must be at least 2 millimeters, or even better, more than 2. Because sometimes, if the abutment is metallic, we have also the problem to mask the transparency of the metallic structure through the soft tissue, and so we have also to increase the thickness of more than 2.5 millimeters in order to be sure that the patient does not see this dark area during the smile because of the transparency of the metallic structure below. So we know that the thickness of this tissue, in order to prevent gingival recession, most probably must be much, much more than the thickness of this tissue, because you know gingival recession can form also in the natural tooth, but it's less probable because at least this gingiva is attached to the root with a very, very good quality of the attachment, which is called connective tissue attachment, which can be destroyed only by periodontopathogens bacteria and not only by bacterial in general in terms of inflammation. So gingival recession can form in both teeth, but one tissue is very well attached with the connective tissue, while the others, it's only a pocket that must remain a pocket, or if you want to call it transmucosal soft tissue, you can call it transmucosal soft tissue, but it is enough plaque or inflammation forming this area, and this tissue will recede. So I absolutely believe that the thickness of the tissue here cannot be like the thickness of the soft tissue at the level of the tooth, because we have, for at least 3.5 millimeters, this tissue that is not attached at all to the underlying surface. So now it comes the definition of soft tissue adhesions around the implant, and soft tissue adhesions around the implant is not the metallic exposure of the implant surface. It is too late. I can tell you that in my opinion, and this is what I also wrote, is that gingival recession starts once there is a disalignment with respect to the soft tissue margin of the implant-supported crown and the adjacent or homologous natural tooth. This is the first the starting point of gingival recession, independently if there is or not metallic exposure. If the metallic exposure belongs to the abutment, this is a problem that can be quite easily solved with a surgical and non-surgical approach that I will show you after, but can be solved because the metallic, if it's exposed at the level of the abutment, you can change the abutment, use a new abutment that is for sure not contaminated, and so there is no problem of decontamination. The main problem is once the metallic exposure belongs to the implant surface, implant rough surface, that portion, that surface of the implant that can be osseointegrated. In this case, we cannot obviously remove the implant to decontaminate the implant surface because this would be the second solution we have in this case, that is called implant extraction. And so we have to think about how predictable we are in the implant surface decontamination, and this is not for sure. So we should treat gingival recession before exposure of the implant rough surface. And the objective of the therapy, the objective of the coverage of these soft tissue adhesions is not only to increase the thickness of the soft tissue apical, is not only to mask the metallic exposure, but what the patient asks us as a goal, ideal goal of the treatment is to reline the soft tissue margin of the implant-supported crown with the soft tissue margin of the homologous natural tooth. And this is called complete coverage. Exactly the same term we use for the treatment of gingival recession. Once we are able to replace the soft tissue margin of the implant-supported crown exactly at the same level of the soft tissue margin of the natural tooth. This is the goal of the therapy. This is what the patient is really interested. It's only one goal, is complete coverage. Not always is it possible, yes we know, but we have to know this from the beginning because we have to make the patient aware that what is his expectation, namely to have the tooth exactly like the adjacent one, is not possible to be achieved. But there is only one goal, ideal goal of the treatment of the soft tissue adhesion that is called complete coverage. But this is not enough. It's not enough to cover completely the crown. It's also necessary that this soft tissue that is used to cover the implant-supported crown does not recede back. So to prevent risk of gingival recession or soft tissue adhesions recurrence in the future. So we have to give to this tissue that is covering the implant-supported crown at the same level of the homologous natural tooth also the right thickness to prevent gingival recession to form. And this right thickness means that starting from the soft tissue margin in apical direction, this should be greater or at least equal to 2 millimeters. Because you see in two different biotypes, the inflammatory process, if you have a very thick soft tissue, occupies only a part of the thickness of the connective tissue. So here there is still some connective tissue not invaded, not destroyed by the inflammatory cells, which maintains the soft tissue margin, that is where the extraoral epithelium with the intracircular epithelium meets in the same position. So no gingival recession form. While if the thickness of the connective tissue is so thin that the whole thickness of this connective tissue is occupied by inflammatory cells, and this thickness should be about 1.5 millimeters, it means that there is no more connective tissue health that is able to sustain the soft tissue margin in this position, and you will experience gingival recession. So it is critical not only to cover at the same level, but to give to the soft tissue margin where we are going to place our new implant-supported crown the right thickness. And this right thickness should be at least 2 millimeters starting from the soft tissue margin. And this is not enough. We need that this thickness of 2 or more than 2 millimeters will be extended for at least 3.5 millimeters in apical direction, where finally we may have bone protecting the implant surface from the risk of gingival recession to form. So the goal of our therapy is to give the implant-supported crown a soft tissue thickness of at least 2 millimeters, starting from the soft tissue margin of the implant-supported crown, for 3.5 millimeters in apical direction. And now this is the way to protect gingival recession to form. The presence of bone at the level of the implant, at the level of the implant platform, at the level of the implant portion that is possible to be osseointegrated is a further important aspect to prevent exposure of the implant surface once gingival recession has already started 3.5 millimeters more corner.